You very much for your kind presentation, Kostas, and also really thank Professor Kotsis for his very kind invitation. So I was asked to talk about eligibility for renal denervation, and I started with a case, and these are my disclosure. So the clinical scenario is a 60-year-old man of African origin. He has a 5-year history of type 2 diabetes, treated with metformin and GLP-1 agonist. He has obesity with a BMI of 32 kilogram per square meter. He has obstructive sleep apnea treated with CPAP, but he has a very poor adherence to his to CPAP. His hypertension is present since 15 years and treated with logical and recommended treatment with amlodipine, 10 milligram per day, irbesartan, angiotensin antagonist at the highest dose, 300 milligram per day, a good diuretics, type diuretic indapamide, 1.5, and he has also a high dose of spironolactone of 50 milligram per day, which was also titrated. He has a history of TIA, and there is a presence of left ventricular hypertrophy at echography. So he's already with a complicated hypertension. He complains of sexual impotence and gynecomastia with the treatment. So on clinical examination, of his blood pressure is 162/96, BMI 32, weight circumference 110, normal clinical exam. Uncontrolled and resistant hypertension is confirmed with daytime ABPM 150/92 and nighttime ABPM 142/86. And the drop during nighttime is not so important. So he has also very constant hypertension over the circadian cycle, increasing his cardiovascular risk. Fundoscopy show a mild non-proliferative retinopathy. eGFR is already altered and decreased to 60 mL per minute. Serum potassium is high, 4.9 millimole per liter. He has a mild proteinuria. His blood cholesterol, LDL cholesterol is plus minus control with statin. HbA1c 7.5%. We checked whether he had primary aldo, and his plasma renin concentration is more elevated, and his plasma lustrine concentration is also elevated. ECG showed nothing very particular, but the echocardiography confirmed the left ventricular hypertrophy with a left ventricular mass index of 130 gram per square meter and with a normal ejection fraction. So we pushed also the investigation. We checked whether he was taking or not his medication, and we also did some imaging. Here, the CTA imaging showed normal adrenal glands, and in fact, there was nothing, no biological clue of primary aldo. And this is his renal artery anatomy. He has multiple calcification of the aorta, of the ostium, of the renal arteries, and he has, as you see, a unique main left renal artery and two renal artery on the right side, one accessory, which is very small, and one main principal renal artery of correct diameter. So if we go back to the presentation of Professor Redon, so these are the recommendation of the European Society of Hypertension. And as you see, unfortunately, the mouse doesn't, oh, yes, I have it here. We are at this stage of this patient's receiving everything until spironolactone. He has CPAP therapy for his obstructive sleep apnea, and adding medication, since at this stage he doesn't want to take anymore, as something complex. So what we know that the aldosterone antagonist have a beneficial effect in terms of blood pressure reduction here when compared to a control group or placebo group, given on top of renin-angiotensin system blocker plus diuretic plus calcium channel blocker. And this is also accompanied by an increase in serum potassium. And you see that our patient has this mild increase in serum potassium levels. We also know from this slide was also shown by Joseph Redon that if we look specifically to the blood pressure drop induced by mineralocorticoid receptor antagonists, specifically here, spironolactone, in fact, in reality, if you look to the first line of spironolactone, given on top of a triple therapy here, only 58% of the patients meet target blood pressure. So it's recommended in guidelines, but however, it's not a magic drug, a magic pill, magic bullet treating all patients. You also know clearly because of this steroidal effects of mineralocorticoid receptor blockers. On the right side of the slide, you see that there is a major increase in breast pain, gynecomastia, and also in sexual impotence using spironolactone. And specifically, this man was complaining about this treatment. We also know in the long run that patients, even with, if we start spironolactone, reality, patients stop spironolactone. This is a retrospective study using US pharmacy medical claims. You see on the left side of the drug, I'm sorry, on the left side of the slide, the percentage of day covered with spironolactone around 60%, and the discontinuation before the end of the first year in patients with heart failure. So it's another, but there are symptomatic patients. You see that's more than 70% of the patients do not renew their prescription. Let's go to CPAP therapy. Yes, CPAP therapy decreases blood pressure. This is ABPM data, 4.8 millimeters of mercury in terms of decrease in ambulatory systolic blood pressure. But adherence to this treatment, as you have seen for this patient, was not good enough. So we cannot propose more than this to this patient. So what type of intervention? I'm not sure that it's the best way to treat this patient and to put all the medication in his mouth, like here for the goose and the foie gras in France. And we can propose alternative therapies. And here I would like to give you some evidence about the use of denervation therapy for treating this type of patient. He has a metabolic profile, he's obese, he's not so old, so he may benefit from renal denervation. And I show you here the different catheters from radiofrequency-based renal denervation, ultrasound-based denervation, and alcohol-mediated renal denervation. These three ways of doing renal denervation show short-term safety and also long-term safety for the first one, and short-term efficacy until up to 6 months in on-med and off-med studies. This is the most recent meta-analysis of renal denervation on ambulatory blood pressure in patients with or without antihypertensive medication. The upper part of the slide shows the ABPM reduction in unmet trials. So there is a mixture of different trials, as you can see here in this meta-analysis, which also mixed first generation trials, such as Simplicity HTN3, the DASH trial, which was done with another type of catheter. And we know there are different methodological flow, which impacted also the magnitude of the drop in blood pressure observed in this trial when you do the meta-analysis of this trial. This is obvious when you see the variability of the different changes in blood pressure and the upper part of the slide. So the overall effect is around 3.5 millimeters of mercury, but you see that the radiance on, the spiral on MEN study had a difference between groups of 7 millimeters of mercury systolic blood pressure, and in the radiance trio, which I will show you now, 4.2 millimeters of mercury. So Radiance Trio trial, which was published just last year, was a dedicated trial for renal denervation in patients with resistant hypertension. So this trial included patients with confirmed resistant hypertension on ABPM after switching them to a single pill combination therapy of a calcium channel blocker, a renin-angiotensin system blocker, which was an angiotensin II antagonist, and a diuretic in a single pill. So patients were followed during 4 weeks, new ABPM. If the ABPM was uncontrolled, they were randomized in a denervation group using the ultrasound-based renal denervation with the Paradise catheter, or a sham procedure, which was restricted to only angiography. So these are the data. On the left part of the slide, the intention to treat population with a drop in blood pressure after 2 months follow-up of daytime ambulatory systolic blood pressure of 8 millimeters of mercury. In the sham group, because there was addition of medication, a drop of 3 millimeters of mercury. The difference was 4.5 millimeters of mercury. And if we focus on those who had no missing ABPM, because we were hit also during the trial by the COVID and there were missing ABPM, you see that the drop in blood pressure was 9.7 millimeters of mercury in the denervation group and 3 millimeters of mercury in the sham group. And the difference was, in terms of daytime ABPM, systolic blood pressure, was 5.8 millimeters of mercury. What is very important is the right part of the slide, where you see that we check medication adherence by urine drug detection, and the majority of the patients, which are the blue bars, were highly adherent to treatment with an adherence of around 80%, which remains stable from baseline to 2 months and similar in the both groups. So you also know that when you do renal denervation, you have an effect which is present during daytime and nighttime. So these are the curves, the ABPM curves. Black line is the baseline, the green line is after denervation, so 2 months after denervation, one-shot procedure, and you see either daytime and nighttime drop in blood pressure, which is probably has an impact in terms of prognosis. However, we also know that there's a very large variability between patients in the response to renal denervation. The upper part of the slide shows the denervation group, and the down at the bottom part, the sham group. And we would like to have to focus on those who will have the greatest response. I just skipped this. So I give you also the data we are going to publish in the next few weeks concerning which these data were presented at TCT. What happened when we add medication from 2 to 5 months? And these were the recommended drugs which were given from 2 to 5 months: spironolactone 25 milligram, a beta blocker, a centrally acting drug, and then an alpha blocker. So, and the basis to give this medication was made on home blood pressure monitoring. So at each monthly visit, if the home blood pressure target was not achieved, physicians who were maintained blind to the randomization could add these medications. So what happened at 6 months? You see at these lines, which are highlighted in red, that the change in antihypertensive medication was larger in the sham group than in a renal denervation group. But mainly what was extremely different was the percentage of patients who received aldosterone antagonists, which was in the vast majority of cases, spironolactone 25 milligram. So 40% of them received spironolactone in the denervation group against 60% in the sham group. So this was highly statistically significant. These patients were still adherent to treatment. These are in the blue bar shows you have a slight decrease in adherence to treatment because you're adding medication on top of a triple, on a single pill, triple combination therapy. However, the difference between the two groups were similar. So what happened in terms of blood pressure? So the upper part of the slide shows you the increment of proportion of patients who are receiving an aldosterone antagonist at each visit. And you see the lower part of the slide shows the home blood pressure decrease at each visit. So the difference between the two groups and the overall decrease in blood pressure was 4.5 millimeters of mercury in terms of systolic blood pressure, which was maintained throughout the 6 months. Some very new data have been published by Felix Marfoud with the spiral catheter, which are the long-term efficacy of this renal denervation up to 36 months of the initial cohort of patients randomized in the spiral unmet study. And what is observed is this. So just focus on the 24-hour systolic blood pressure. So in green, the sham group, and in blue, the denervation group. The difference between the two groups is maintained after 36 months. And what is very important is that the number of medications is similar, slightly increasing with time with this difference in blood pressure, but also the medication burden and with a parameter including also the dosage of the medication shows that the sham group received finally more medication. So, and again, we see clearly here the 24-hour systolic blood pressure drop with the denervation group. This is the blue line on the bottom of these different profiles. Let's skip this. Some new information, indirect information, are also provided by the Philippe Lurtz group. These are some long-term outcomes of responder versus non-responders to renal denervation in resistant hypertension. This is only an observational retrospective study. You see on the left side of the slide that blood pressure responders were diagnosed by a drop in blood pressure above ambulatory blood pressure above 5 millimeters of mercury for systolic blood pressure. And you have 180 patients who were responder, and a non-responder was 116. So, and you see clearly that I make a mistake here. So the 6 months responders and 12 months responders is 12 millimeters of mercury and 11.7 millimeters of mercury, in contrast with 2.8 and 2 millimeters of mercury. On the right side, you have the MACE, and there is a significant reduction in MACE, but the number of events are very small. So these are some indication that if you look the blood pressure response to renal denervation, they may impact also the occurrence of MACE and ischemic events. So this is the patient you've seen previously. This is his renal angiogram. We have made, and Marc Sapoval was doing this procedure using the balloon catheter, which is here inside the renal artery. So the follow-up of the patient are, this is what has been obtained. The office blood pressure was 132/82. Daytime ABPM was massively reduced to 25/80 millimeters of mercury, and nighttime ABPM 120/78 millimeters of mercury. As you see, the antihypertensive treatment remains similar with the exception of spironolactone, which was stopped, and the patient was very happy. eGFR remains stable, serum potassium was normalized, proteinuria went back to 0, and there is a slight decrease in the left ventricular mass index. So in this patient, we had different predictors of the response to renal elevation. His age, he was not too elderly. He was a Black patient. He has obesity, sleep apnea, and also he had chronic kidney disease, plus minus not very well adherent. So this were about his patient characteristics. You see that if we look to the different hemodynamic parameter, his baseline blood pressure was elevated, and his nighttime systolic blood pressure was elevated. And despite aortic calcification, he had an important response to renal denervation. There have been multiple, I took this slide, I think, from Costas, which is the compilation of all the guidelines which have been published up to now. And we hope that for the next ESC meeting, we will have new European guideline. And basically, they say the same thing. These are the universal patient consideration. So we should check that blood pressure is uncontrolled despite attempted antihypertensive medication, rule out secondary hypertension, identify and rule out white coat hypertension with elevated out-of-office blood pressure, evaluate the global cardiovascular risk and hypertension-mediated organ damage, or in patients with established cerebrovascular and cardiovascular disease. This patient had all this. And the emphasis should be placed on individual treatment and patient preference. So the patient wanted to have this denervation, and it is necessary to follow up really strictly this patient. Thank you very much for your attention.